I keep to time, so we'll make a start. We have our two presenters here already. Hopefully the third one will join us soon. Welcome to this session on HIV, opportunistic infections, and epidemiology. My name is Dr. Nana Aigua-Higgins-Seniaja. I'm a physician by training, and I'm with the University of Ghana Medical School. I have special interest in chronic diseases, including HIV. So I think I'm in the right place. You're welcome to this afternoon's session. We have three speakers, and so I will call them up to the stage. And I'm doing this because I want you to look at them closely, listen to them well. And then after every speaker, I'll give you just 1 minute so that you can put your questions down. When I sat in the previous session, I realized all the questions went to the third speaker because that's what people probably remembered. And so I don't want you to lose track of what other speakers have said. So I will entreat you to put down your questions after every speaker, and I'll give you the time. So we have three speakers. We have Dr. Hassan, Dr. Kamena Hassan, yes, from Morocco. So you join us upstage. We have Dr. Isaac Kyeremateng from Ghana. You also join us upstage. And then we have Mr. Lucky Makonokaya. Sorry if I've butchered your name. If you are here, please join us. We hope he can join us soon. We all know how important opportunistic infections are in HIV, especially among those with advanced diseases. We are going to hear presentations from 3 different countries, and so please pay attention. Every presenter has 10 minutes. Hopefully the third one will join. If he doesn't, we will give the extra 5 minutes to participants to ask questions. So we'll start off with Dr. Hassan. I'll say a little bit about Dr. Hassan. Dr. Hassan is an infectious disease physician with the Department of Infectious and Tropical Diseases at Ibn Rochd University Hospital in Morocco. I hope I got that right. Good. He's been a participant at several international congresses on infectious diseases. He's also done some internship in France, also on infectious diseases. Dr. Hassan, thank you very much for being here. You have 10 minutes to tell us what you have on opportunistic infections. Please, let's clap for him. It's not easy being upstage.
Good morning, bonjour. Mesdames et messieurs les membres d'organisation, chers invités, je suis très heureux d'être honoré par les membres du comité d'organisation en me choisissant comme orateur à ce majestueux congrès où participent les éminents scientifiques dans le domaine du VIH, et je les en remercie sincèrement. Thank you very much. Je suis heureux de vous présenter notre travail réalisé au CHU Ibn Rochd de l'université Hassan de Casablanca, au Royaume du Maroc. Donc, le travail est intitulé Toxoplasmose cérébrale chez les patients VIH, vivant avec le VIH, à Casablanca. Il s'agit d'une étude rétrospective.
Dr. Hassan, sorry to interrupt you. Please, can you project the QR code for people to get interpretation of his presentation? Okay. So that we can all follow what you're presenting. Just a minute. Give us a minute. So your timing has stopped.
Okay.
Yes. Sorry about that. Yes, so you can scan the QR code so that you can get interpretation of the presentation as Dr. Hassan goes on. Thank you. Yes, please, you can.
Alors, les auteurs qui ont participé à cette étude donc, déclarent n'avoir aucun conflit d'intérêt. Voici le plan de notre travail. Ok. Alors, l'infection à VIH se caractérise par la présence d'infections opportunistes touchant le plus souvent le système nerveux central. Plusieurs auteurs décrivent la toxoplasmose cérébrale comme une infection opportuniste du système nerveux central survenant chez les patients VIH, avec une prévalence mondiale de 25 à 30%, en particulier dans les régions où l'infection VIH est très répandue et où l'accès aux antirétroviraux est limité. La prévalence de la toxoplasmose cérébrale est très élevée dans le continent africain, particulièrement au Soudan du Nord, en République démocratique du Congo et en Éthiopie. Au Maroc, les données ne sont pas bien précises, mais il y avait une étude descriptive qui a été réalisée au CHU de Marrakech au Maroc, qui a mis en évidence une prévalence de la toxoplasmose cérébrale à 4,63%. La toxoplasmose cérébrale survient chez les patients VIH dont la charge virale est supérieure à 50 copies et le taux de CD4 est inférieur à 100 cellules par millimètre cube. Alors, quels sont les objectifs de notre travail? Premièrement, c'était de déterminer les caractéristiques épidémiologiques, cliniques, biologiques, radiologiques, histologiques et thérapeutiques. Deuxièmement, identifier les co-infections neurologiques en dehors de la toxoplasmose cérébrale. Alors, il s'agit d'une étude descriptive portée sur le patient VIH dont le diagnostic principal était la toxoplasmose cérébrale et qui était réalisée au service de maladies infectieuses du centre hospitalier universitaire Ibn Rochd durant la période du 1er janvier 2021 au 31 décembre 2023. Et le diagnostic de la toxoplasmose cérébrale était basé sur des arguments cliniques, sur la sérologie antitoxoplasmose IgG positive dans le liquide cérébrospinal et dans le sang, les images radiologiques, ainsi que l'amélioration clinique sous traitement antitoxoplasmose, à savoir sous cotrimoxazole. Les variables utilisées dans notre étude étaient les variables épidémiologiques, cliniques, bilan bactériologique du liquide cérébrospinal, bilan biologique, la sérologie antitoxoplasmose dans le sang et dans le liquide cérébrospinal, l'examen anatomopathologique, les images radiologiques ainsi que la présence de co-infections neurologiques. Et l'analyse statistique était réalisée par l'application SPSS version 5. Alors, comme résultat, au total, durant cette période, on a recueilli 17 patients, dont l'âge moyen était de 42 ans, le sexe ratio était de 1,4, le sexe féminin était prédominant dans 59%, et il y avait deux groupes. On avait scindé deux groupes. Il y avait les patients chez qui le diagnostic était confirmé durant l'hospitalisation, et les autres chez qui les patients étaient déjà suivis pour l'infection à VIH. Chez les patients diagnostiqués durant l'hospitalisation, 11 avaient une charge virale moyenne de 2 21 090 avec un taux de CD4 à 86 cellules, et 3 patients avaient une charge virale indétectable, mais on a confirmé par le Western blot, et le taux de CD4 était à 148 cellules par millimètre cube. Dans le deuxième groupe, donc les patients qui sont déjà suivis pour l'infection VIH et qui sont sous traitement antirétroviral, un seul patient n'était pas contrôlé sur le plan immunologique et virologique, donc il avait une charge virale à 748 617 avec un taux de CD4 à 21, et 2 patients étaient contrôlés sur le plan immunologique, virologique et immunologique. À l'examen clinique, la manifestation clinique la plus importante, les manifestations cliniques les plus importantes mises en évidence chez nos patients, c'était premièrement le syndrome méningé, chez 15 patients, et chez qui l'examen cytobactériologique du liquide cérébrospinal a confirmé une méningite à liquide clair lymphocytaire avec une pléocytose à 803 éléments, une hyperproteinurachie élevée avec une moyenne de 3 grammes et un taux de glucorachie qui était bas avec une moyenne de 0,30 grammes par litre. La deuxième manifestation, c'était le déficit moteur. Troisième manifestation, l'encéphalite. Et quatrièmement, le triade de Bregman. Le triade de Bregman comprend le syndrome infectieux, le syndrome d'hypertension intracrânienne ainsi que le syndrome de focalisation. Comme infection, la sérologie antitoxoplasmose IgG était positive dans le liquide cérébrospinal et dans le sang chez tous les patients. Comme infection opportuniste qu'on a mis en évidence en dehors de la toxoplasmose, c'est l'encéphalite ACMV chez 4 patients, la cryptococcose méningée chez un patient. L'IRAM cérébral était resté chez tous les patients hospitalisés, mettant en évidence des lésions sus- et sous-tentorielles avec un œdème périlésionnel. Et sur le plan thérapeutique, tous les patients étaient admis pour toxoplasmose étaient traités sous Bactrim, donc le cotrimoxazole, en raison de 2 grammes toutes les 8 heures, associé avec l'acide folinique. Malheureusement, on n'en avait pas, mais on les a mis sous acide folique, et associé avec la corticothérapie. La durée était pendant 6 semaines, et le traitement d'entretien, on a fait à demi-dose. Donc, il y avait un seul patient qui avait mal évolué sur le plan clinique et radiologique, malgré le traitement de Bactrim, et chez qui nous avons réalisé la biopsie stéréotaxis, et l'examen anatomopathologique qui était complété a mis en évidence des tachyzoïdes, qui est la forme réplicative de la toxoplasmose, qui était mis en évidence par immunomarquage. Dans la discussion, donc, la toxoplasmose cérébrale est la plus fréquente infection opportuniste du système nerveux chez le patient VIH et survient très souvent par réactivation d'une infection latente quand le taux de CD4 est inférieur à 100. La moyenne d'âge dans notre étude était de 44 ans, ce qui était la même dans certaines études réalisées au Danemark, au Sénégal et au Brésil. En Russie, Azosteva a objectivé une prédominance masculine. Par contre, dans notre étude, on avait mis en évidence la prédominance féminine, la même chose comme l'étude de Sissoko au Sénégal. Comme manifestation clinique, l'encéphalite multifocale est la principale manifestation clinique de la toxoplasmose, d'une manière générale, selon la revue de la littérature. Mais chez nous, nous avons mis en évidence comme manifestation clinique le syndrome méningé. La sérologie toxoplasmose positive dans le liquide cérébrospinal a une sensibilité élevée, mais une spécificité très faible et confirme la probabilité de la toxoplasmose cérébrale. La PCR du liquide cérébrospinal est l'étalon d'or dans le diagnostic de confirmation de la toxoplasmose cérébrale avec une spécificité de 96%. Mais elle a une mauvaise sensibilité, raison pour laquelle la PCR toxoplasmose dans le liquide cérébrospinal négative n'élimine pas le diagnostic. Comme infection, autre infection opportuniste, dans les études réalisées au Sénégal et au Brésil, comme infection opportuniste, c'était l'encéphalite ACMV. Par contre, au Ghana, une étude qui a été réalisée au Ghana avait mis comme co-infection neurologique l'Epstein-Barr virus. En conclusion, le diagnostic de la toxoplasmose cérébrale nécessite une synergie des bilans biologiques, radiologiques, anatomopathologiques pour mettre en évidence la probabilité ou la confirmation dans le but d'améliorer la prise en charge thérapeutique. Je vous remercie et merci Akwaba.
Thank you very much, Dr. Hassan. Thank you. Today I've gone deep within my brain to try and remember all the French that I learned years ago. But thank you very much. So please, I'll give you 1 minute to jot down your questions for Dr. Hassan so that you don't forget it. Whilst Dr. Kyeremateng prepares to join us. So please write your questions down. I don't want what happened with the previous presentation to happen, where every question was directed at the last presenter. Okay, so our next presenter is Dr. Isaac Kyeremateng, who is with the University of Ghana Medical Center, that very beautiful structure you see in the heart of Accra. He's a researcher, and he's interested in the application of AI to address pressing research questions in HIV research. He has a strong foundation in clinical medicine, public health, and biomedical informatics. And this strategically positions him to be able to work in the field of data science, global health, and infectious disease outcomes. So without talking too much, I will hand over the podium to Dr. Kyeremateng to present another aspect of opportunistic infections in HIV disease. And then hopefully you listen to this one too and jot down your questions. because our third, I don't know if Lucky has joined us whilst the presenter was giving the presentation. Okay, so because our third presenter is not around, we'll have a bit more time for more questions. So thank you very much.
All right, good afternoon. My name is Dr. Kyeremateng, a clinical data scientist with the Medical and Scientific Research Unit at the University of Ghana Medical Center. And go to the previous slide, So with my collaborators from the Korle Bu Teaching Hospital, I'm presenting our work on titled High Mortality from Cerebral Toxoplasmosis Among People Living with HIV in a Tertiary Facility in Ghana. Next slide. So cerebral toxoplasmosis is the leading cause of focal brain infections in adults living with HIV. It's also an advanced HIV disease, which is marked by high short-term risk of morbidity and mortality. In 2024, the WHO reported rising cases of advanced HIV diseases in newly diagnosed infections, as well as in over 30% of those re-engaging in care. In 2015, cerebral toxoplasmosis accounted for approximately 15% of all inpatient deaths among people living with HIV worldwide. Now, unfortunately, the data on the distribution and the clinical outcomes of HIV-associated cerebral toxoplasmosis has been limited, especially in our settings. So our team set out to assess the clinical outcomes of cerebral toxoplasmosis among inpatients at the Korle Bu Teaching Hospital, which is one of the biggest tertiary facilities in Ghana. Next slide. So this was a descriptive study where we retrospectively reviewed the admission records of patients between 2012 and 2020. So these were patients who were aged more than 18, admitted at the infectious disease unit of the Korle Bu Teaching Hospital. Now, we collected social demographic and clinical characteristics from these patients, all of which were managed for cerebral toxoplasmosis. And our outcomes were whether they died or they were discharged. With these characteristics, we ran a multivariable model to look at some factors that were associated with mortality. Next slide. So over the period, we had 6,741 admissions. We were interested in the central nervous system related advanced HIV diseases. So this was 226. Now from those, cerebral toxoplasmosis cases were 205. So that gave us a period prevalence of 3%. Now, looking more keenly at the central nervous system related advanced HIV diseases, we realized that cerebral toxoplasmosis dominates this group. So this group has TB meningitis, cryptococcal meningitis, but as you can see, cerebral toxoplasmosis is about 90% in this group. Next slide. So in cases that were diagnosed for cerebral toxoplasmosis, majority of our patients were female. Most of our patients were between 25 to 29, and more than half of our patients were newly diagnosed. For our admission outcomes, and this is a very critical point, 2 out of 3 patients died, and more than half of these deaths were in the first 72 hours. Next slide. So for neuroimaging, less than half of our patients were able to do the requested neuroimaging. We usually request head CT scans. So for the head CT scans requested, about 11% come back normal. For the ones that were abnormal, majority of them had the focal lesion, which is the characteristic ring-enhancing lesion, but a few of them that did not have lesions had just diffuse edema or diffuse infarct. We went ahead to characterize the focal lesions. So we saw that majority of our lesions were in the cerebrum and the basal ganglia. Next slide. So running a secondary analysis with a multivariable regression, we saw that the deaths in the first 72 hours was statistically significant because deaths in this period was about 3-fold. Now, clinical factors associated with the mortality were having a low Glasgow Coma scale and neck stiffness. So both of which increase the odds of mortality between 3 to 3.5 folds. Next slide. So we put all this together, and what does it mean? It means that we recorded high mortality from cerebral toxoplasmosis in our patients at the Korle Bu Teaching Hospital. We compared our findings with an earlier study done in another tertiary institution, and in a cohort of about 143 patients, the mortality they recorded was 34%. A recently published study from Cameroon they had a smaller cohort, that's like 39 patients, and they recorded mortality of 24%. For secondary analysis, we realized that the mortality in the first 72 hours was also significant, and we believe that this is due to the initial disease severity and or lag in treatment. Now, the factors that were associated were low Glasgow Coma Scale and neck stiffness. Both of these actually indicate severe disease, but especially with the neck stiffness, some studies have also shown that when patients have cerebral toxoplasmosis and neck stiffness, there may be coexisting bacterial and tuberculous meningitis. So if you are treating the cerebral toxoplasmosis and you don't realize this, you realize that your treatment may not be working. That is why these people had an increase in the odds of mortality. So our conclusion is that cerebral toxoplasmosis is dominating the CNS-related advanced HIV diseases in our patients. Mortality was high, with most of the deaths occurring in the first 72 hours. Now, clinically relevant features that we saw from our cohort was having a low Glasgow Coma Scale and neck stiffness. What our recommendations are is that national programs should improve case finding strategies and link it to care. This will put our patients early on ART, therefore averting advanced HIV diseases. Now, clinicians, especially those who take care of people living with HIV, should have a high index of suspicion for cerebral toxoplasmosis in patients who are hospitalized, to initiate prompt empiric therapy, because we have a therapy for preventing some of these advanced diseases. Clinicians should also keenly monitor patients who come in with severe diseases. We know that we have some logistic challenges when it comes to intensive unit care and stuff, but I mean, with keen monitoring, we will be able to avert a lot of these mortalities. So these are my references. Thank you. Next slide. So you could scan this QR code to connect to me. Thank you.
All right. Thank you very much, Dr. Kyeremateng. We are doing very well with time. Lucky. Is Lucky here? Okay. Since we don't have Lucky, I hope you have your questions ready for our two presenters. Sorry. You have a question for him. Okay, so our first presenter has a question for the second presenter. That's a new one. Thank you.
Thank you. Doctor? Very, very much. Communication is very good. Okay. One question, bon. En français, mais je vais me débrouiller pas mal. Ok. Je voulais juste savoir, chez vos patients, vous avez beaucoup de la mortalité très élevée. The mortality in study is high. Yeah. Okay. Why mortality is high? Oh, absence without computer scanner, or difficulty to diagnostic toxoplasmose, or another problem, or another difficulty.
All right, thank you very much. So if I'm understanding you, you are asking why the mortality is high. What are some of the factors associated with the high mortality, right? You want to know why? Yeah, so we realize that we still have late HIV diagnosis in the communities, right? As you can see, more than half of our patients with cerebral toxoplasmosis were newly diagnosed. Newly diagnosed was defined as patients who were diagnosed within 1 month, or they were not linked to any ART site. So these were people who actually once we are diagnosed with cerebral toxoplasmosis, we are actually also diagnosing them of HIV. You understand? So late presentation. Now, the other thing is also late identification, or delayed in initiation of ART. We know once you are diagnosed and put on ART, you are able to avert some of these advanced diseases. There's also the advanced HIV diseases screening and management guideline, and we believe that there may be also some implementation lacks. So these are the points we believe are associated with this, because that is the study was from a tertiary facility, which is like a referral facility. So this is how people present from the communities. And we believe that we need to do more case finding, we need to do more linkage to care to avert this. Yeah.
Thank you very much. Let's give our presenters a round of applause. It's not easy standing in front of such powerful people to present. Please, are there any questions? We'll take from the different sessions. Yes, madam.
So thank you very much. My question is for Dr. Kyeremateng, but I also want to thank you for your presentation. I have a quick comment and then a quick question. The comment is that, my name is Nadia Sam, by the way. I'm a pediatric infectious disease doctor, and I also treat HIV patients. What we find out with these is that this is one of the conditions for which stigma and discrimination are killing people. That there are people who, when they start getting ill, they themselves know they are ill. They may or may not know they have HIV, or they know they have HIV and they are in significant denial, so will not present for care, or their families may not present them for care, and they deteriorate at home, and they come in very, very sick and close to death. And I've had patients like that. My question, so part of the recommendations being that we need to screen and refer is also that we need to really work on the stigma and discrimination that people living with HIV are dealing with. The self-stigma and then the stigma coming from society. My quick question is, the question was that what were the other forms of CNS-related AH you were seeing apart from the toxoplasmosis? Thank you.
Thank you very much. Are there any other questions so that we can take them together? Okay.
Okay. So my question. As a disease program. So mine is just a clarification. Do you have any laboratory tools in diagnosing toxoplasmosis, or you just by clinical science and management? Thank you.
Thank you very much.
Okay, thank you very much. I wish to appreciate the work you've done, both of you. And the colleague from, is it Morocco? My question will be in English. I hope you'll be able to hear or understand what I'm going to ask. Right? So, I saw your method for diagnosis of the cerebral toxoplasmosis. And I think it's a bit linked to what a colleague from Ghana was doing. But I want to find out, I saw something on the serological marker, which is on the IgG, anti-toxoplasmosis. I know that IgG is usually for chronic markers of infection. So I was wondering, why wouldn't you emphasize the IgM? Seeing that even in toxoplasmosis treatment, when you have successfully treated, the IgG may linger on in your assay for a period of time. So if it was forming a significant part of your conclusion that this might be CNS toxo, I think it could be misleading. Then linked to the other question, maybe this one can go to both presenters. If our mainstay of diagnostic is radiological, then you would want to ask yourself, is it very categorical? If you don't find the very significant or characteristic features on your radiological film, how confident do you become that this is indeed CNS toxoplasmosis or toxoplasmosis infection? Could it not be any other form of infection? Or could we not be having a mixed infection? And if it's a mixed infection, how did we control for them so that we didn't conclude that this is CNS only? And for which reason CNS toxoplasmosis, for which reason we probably are having a high mortality? I don't know whether you get my question. Thank you.
All right, thank you very much. Just so that we don't lose our responses, let's let them take the questions as were asked. I think the first one went to you.
All right, thank you
The
very much,
comments
Professor Nadia Sam.
Yeah.
The other forms of advanced HIV diseases were tuberculous meningitis, cryptococcal meningitis, also bacterial meningitis, but also we had one case of progressive multifocal leukoencephalopathy, and those were actually what were our top cases. Yes, please. And okay, the lab.
Okay, you can take that the next one.
Someone asked about the lab too. So we know that, well, ideally we should use a brain biopsy to, diagnose cerebral toxoplasmosis, but that is too invasive. So then we revert to neuroimaging. Now, studies have shown that MRI is actually better than CT scan, but we know our parts of the world. So we use CT scans. So our preferred diagnostic tool would be a CT scan, but as I presented, less than half of our patients, due to logistic and financial barriers, are able to do this. So then we combine both the clinical signs and symptoms and the imaging. I hope you are getting me. Now, also, advanced HIV diseases, usually if you have a CD4 count less than 200, we know we are categorized as having an advanced disease, so we are, looking at you very critically. So these are some of the things we use for diagnosis.
All right, thank you very much. And then to you, I don't know if you got the question. Why IgG and not IgM, right?
Ok. Dans notre étude, normalement, la confirmation de la toxoplasmose, ça se fait soit sur le plan biologique, soit par la PCR, soit on fait la sérologie où on trouve IgG, IgM positif, le 2, dans le liquide cérébrospinal, pour confirmer la toxoplasmose cérébrale. Mais chez nos patients, on n'a pas trouvé le IgM qui était positif. Mais le IgG était positif avec un titrage très élevé, et dans le liquide cérébrospinal, et dans le sang. Mais la confirmation, je peux dire le diagnostic probable de la toxoplasmose, nous sommes basés sur l'amélioration clinique sous traitement thérapeutique. Donc, on a mis le traitement de bactéries en se basant sur les arguments cliniques, radiologiques, et s'il y a une bonne évolution sous le bactérie, ça signifie que le diagnostic de la toxoplasmose est le plus probable. Voilà. Concernant l'IRM cérébral, normalement, bon, ça dépend de chaque pays. Au Maroc, on a cette possibilité de faire le scanner cérébral, l'IRM cérébral le plus tôt possible. Voilà. Et vu que l'IRM cérébral a une bonne montre des lésions plus spécifiques que le scanner, vu qu'on a cette disponibilité de faire l'IRM, d'où on en profite pour faire l'IRM cérébral le plus tôt possible. Voilà.
Thank you very much. I think I will summarize from my translation that I'm getting here. In their patients, they did not find IgM, which was positive, but IgG was positive with a very high titer, both in the CSF and then in the blood. So I think that may address a bit of your question. But in the confirmation, I can say the probable diagnosis of toxoplasmosis, we based our findings on clinical improvement under therapeutic treatment. So basically, from what I'm gathering, it's a combination of clinical, radiological, and then serological tests to make that diagnosis. Does that help? Thank you very much. So we'll take, have all the questions been answered? You had a question. Has it? Okay, good. We'll take another round of questions. Please, his hand has been up for a while, sir.
My question is for Dr. Hassan, but in French, because my first language is French.
Yes.
Dr. Hassan, vous n'avez pas précisé les comprimés. Vous avez parlé des 2 comprimés de cotrimoxazole. J'aurais bien voulu quand même savoir si vous aviez eu des comprimés de 480 mg ou de 960.
Je crois que j'ai commis, peut-être j'ai omis. En fait, ce sont des comprimés de 800 bar 160.
Yes.
Et on le donne, donc on donne maximum, on donne 6 comprimés pendant 6 semaines, donc le traitement d'attaque. Et après le traitement d'entretien, on fait la demi-dose et jusqu'au moment on va arrêter le cotrimoxazole si et seulement si le taux de CD4 est supérieur à 200, ou soit la charge virale qui est indétectable dans le 3 mois.
Je voulais seulement avoir des précisions
Voilà.
sur cette partie-là.
Merci.
Mais je voulais savoir aussi s'il y a eu des malades mis sous forme injectable.
Non, non.
Et je voulais également savoir si vous donnez systématiquement l'acide folinique avec cotrimoxazole ou
Non.
acide folinique avec sulfadiazine et pyrimétamine.
Normalement, on doit donner l'acide folinique avec le cotrimoxazole. Mais malheureusement, au Maroc, on n'en a pas. On donne que l'acide folique pour essayer un peu de donner un peu, bon, d'éviter les troubles hématopoïétiques du bactérie.
Et aucun malade sous sulfadiazine?
Non, non, c'est pas disponible au Maroc.
Okay, that was an interesting interaction per my translation. So it had to do with, let me get this right. Okay, so they were talking about cotrimoxazole, the tablets that were giving, whether it was tablets that was giving and then the dose that was given, and then also whether they were adding folinic acid. Yes, folinic acid to the cotrimoxazole. So that was the interaction that went on. Yes, and I think Dr. Hassan says folinic acid should be given with cotrimoxazole, but unfortunately in Morocco we don't have it. That's what you said, right? Okay, all right. Thank you very much. Today I'm learning French all over again. Please, are there any questions? Yes, sir.
Thank you. I have 2 questions. The first to the presenter from Ghana. I think, except I'm mistaken, your data set ended in 2020 or 2021. Do you think that there is a change in mortality from 2021 to 2025, considering the efforts that have been put in the fight against HIV in Ghana? Then my second question goes to Dr. Hassan. So considering your cases, you had 17 cases that you studied, and looking at the epidemiology of HIV in Morocco, I want to talk about financing. So you are recommending a combination of clinical, radiological, and serological testing. So is this accessible to everyone in Morocco, or is there some subsidization by your national HIV program to make sure that there is access to those who need this kind of combination of diagnosis for cerebral toxoplasmosis? Thank you.
Thank you very much. Are there any more questions from our participants? Okay.
Thank you very much for your question. So yes, the data set ended in 2020, and we're actually looking at the data after. So we're actually collecting a comprehensive data to look at what has changed after that study. So it's something that is still, the team is still looking at.
Merci pour la question. Au Maroc, Sa Majesté le roi Mohamed VI, que le Seigneur puisse lui donner la protection et qu'il puisse bénir sa famille, a mis tous les moyens pour assurer la gratuité et l'accessibilité thérapeutique pour tous les patients vivant avec le VIH. Tous les bilans qu'on réalise, elle est gratuite. Tous les bilans sont gratuits. Ils ne payent absolument rien. Donc, Sa Majesté a mis tous les moyens pour tous les patients, non seulement pour les nationaux, même pour les étrangers. Donc, tout est disponible et tout est gratuit. Voilà.
Okay, so I think the leader of Morocco, right, is being praised for all the measures he's put in place to ensure that people get free care. And so that's definitely a lot of political will there to support HIV care. So, yeah. All right. Thank you.
Thank you very much. I think just to add, I think it's the combination of, let me say, diagnosis for toxoplasmosis. You must not have all. So as he was rightly saying, the IgG is a chronic marker that you find. So usually you may not want to be using IgG. The neuroimaging, as we said, in our part of the world is limited. So usually use your signs and symptoms. If you have the imaging in addition, you do. The CSF IgG is actually 100% specific and sensitive. So if you do find CSF IgG, yes, your patient has, toxo. But the question is an invasive procedure. And you actually do not want to be doing that routinely in our part of the world, where IPC issues, we have infection prevention control issues. And so with that invasive part, we usually do not do it. So we would use the clinical signs and symptoms, and then you add your neuroimaging if possible. But then you start your treatment for the toxoplasmosis because your signs and symptoms are that suggestive. However, if it is toxoplasmosis you are treating, within 2 weeks, you should have almost 96% of your patients improving. If the patient is not improving, then you should be thinking that it is not only toxo I'm treating, it may be a mixed infection, or it may just also not be toxo. And that will also address his question that he was asking about. If whether we think it's solely toxo that may be amongst the patients. Thank you.
All right, thank you very much. I think our time is up. Please let's give a round of applause to our presenters. I will just conclude with my take home. Back to the basics, starting from what she said, stigma reduction, so that we can get our persons living with HIV coming to get the test done. They are initiated promptly on ART so that we can prevent some of these opportunistic infections and then the advancement of HIV. And then once they get it, we also need to screen and pick it up as quickly as possible. We must have a high index of suspicion and then also think about other co-infections among these clients. So thank you very much for your attention. We weren't many, but I think I totally enjoyed it. Thank you.